Assalamu alaikum. There is another topic which is related with anti-cancer cytotoxic agents, and this topic is termed as anti-tumor antibiotics. As we have all known, the term antibiotics is used for the agents, the microbes, the bacterial agents, and which spread infections in the human body. But here, the antibiotics basically are the cytotoxic drugs which are not used to treat the infections, but uh, related with the anti-tumor activity. So the topic is also called as anti-tumor antibiotics. Basically, the antibiotics termed as due to the isolation and origination of these drugs from the culture of streptomyces. That's why these are termed as antibiotics, anti-tumor antibiotics, and they are further classified into two major groups, that is anthracyclines and non-anthracyclines. Anti-tumor antibiotics are used only to treat cancer. They are not used to treat infections, as I've told you. And all of these drugs injure cells through direct interaction with DNA. Their GI absorption is poor, and due to this poor GI absorption, all the drugs administered IV, that is parenterally. Come towards the anthracyclines. Anthracyclines are the anti-tumor antibiotics, and their derivatives are doxorubicin, which is available in both conventional and liposomal form; daunorubicin, again available in conventional and liposomal form; epirubicin, idrabucin, and valrubicin. Another drug, metuzentron, is also categorized as anthracycline antibiotic, but because of its similarity to drugs in the category. All these drugs cause dose toxicity, that is bone marrow suppression, and heart damage, that is they are cardiotoxic, and they led to fatal heart failure. Treatment with dexrazoxane offers some protection against cardiac damage, that is there is some preventive measure, but not as much as effective as we may um, predict about it. So anthracyclines given in the very limited conditions and in the limited scenario. The conventional form of doxorubicin is active against a broad spectrum of neoplastic disease. Unfortunately, cardiotoxicity limits its use. So doxorubicin is available in two formulations, again conventional and liposomal. The conventional preparation and its discussion as follows. The mechanism is intercalation with DNA and inhibition of topoisomerase 2. That is the two related mechanism. And we can understand intercalation by envisioning the stacked base pairs of DNA as having a structure like that of a stack of coins. Coin-like shape itself, doxorubicin is able to slip between base pairs of DNA, after which it becomes bound to DNA. The process of intercalation distorts DNA structure, and as a result, DNA polymerase and RNA polymerase are unable to use DNA as a template, and the synthesis is inhibited. While binding to DNA, doxorubicin also forms a complex with topoisomerase 2, an enzyme that cleaves and then repairs DNA strand. Doxorubicin allows topoisomerase 2 to cleave DNA but prevents subsequent DNA repair. And in the absence of DNA repair, apoptosis, that is programmed cell death, results. And in this form, the doxorubicin completely kills the neoplastic cell. That is due to this type of mechanism of action. Doxorubicin is also cell cycle phase non-specific. That is, it provided the intercalation of DNA and topoisomerase 2 inhibitor. And in this process, throughout the mitotic cell division, that is, the cell cycle specificity is unclear, and it is related with cell cycle phase non-specific. The kinetics, as we have learned earlier, that PO is not per oral absorption, per oral administration is not possible. So IV infusion and distribution is rapid. It does not cross BBB, that is blood-brain barrier, metabolized in liver, and the patients with hepatic impairment, the doxorubicin doses must be reduced or adjusted according to the patient condition. The metabolites are eliminated in the bile. So it is very important to understand the metabolism and excretion both are from liver. The indication of doxorubicin is against many neoplastic disease, especially the solid tumors and disseminated cancers, specifically Hodgkin's, non-Hodgkin's lymphoma, sarcomas of soft tissue and bone, various carcinomas, including carcinoma of the lung, stomach, breast, ovary, testes, and thyroid. The cardiotoxicity of doxorubicin is very acute and it causes the delayed injury to the heart. The acute effects include arrhythmias, electrocardiographic changes, and it can develop within minutes of dosing. In most of the cases, the reactions are transient, lasting no more than 2 weeks. The delayed cardiotoxicity development 2 years after doxorubicin therapy and manifest as heart failure secondary to diffuse cardiomyopathy. The cardiomyopathy, also termed as myofibril degeneration, and this delayed cardiac injury is directly related to the total cumulative doses. That's why the risk is associated with the doses rises above 550 milligram per meter square. A preventive measure, a product, a drug, dexaroxazone, is used to prevent the heart from doxorubicin at the expense of additional myelosuppression and possible reduction of anti-tumor activity. That is, the cost benefit ratio is very imbalanced in this case, and risk benefit ratio is very imbalanced in this case, and the treatment have two complications. Number one, the drug appear to intensify myelosuppression, which is already done with the use of doxorubicin. The preventive drug dexroxazone is also produce myelosuppression, and it also reduce the anti-cancer activity of doxorubicin. So the benefits of chemotherapy should not be compromised. In the case of dexaroxazone is approved only for patients who have already received 300 milligram per meter square of doxorubicin. Drug is also approved only for patients receiving doxorubicin for breast cancer, and this restriction is due to the intensification of myelosuppression may be greater with tumors other than breast cancer. One more drug is used to prevent cardiac damage, and this is the cardiovascular drug, antihypertensive drugs, that is angiotensin converting enzyme inhibitor, ACE inhibitor, and the drug name is Ramipril. It can improve the symptoms of cardiomyopathy. Furthermore, if given earlier, ACE inhibitor may be able to prevent cardiac damage. So the best option is ACE inhibitor over the dexaroxazone, because ACE inhibitor does not induce the myelosuppression and does not um, suppresses the anti-tumor activity of doxorubicin. So this is the better option, and we also learned the other toxicities associated with doxorubicin, which includes the nausea, vomiting, local injury if extravasation occurs, harmless red color to urine and sweat. And dose limiting toxicity also include neutropenia in case of bone marrow suppression, thrombocytopenia and anemia also occurs. Neutropenia occurs in 70% of the patient. Some more toxicities include alopecia, stomatitis, anorexia, conjunctivitis, and pigmentation of in the extremities. In case of liposomal doxorubicin, the liposomal doxorubicin is a reformulation of conventional doxorubicin, and it is used to increase the delivery of the drug to tumor cell and to decrease its uptake by normal cell. That is, the resistance appear due to doxorubicin liposomal conventional. So the structural formulation has minor changes, that is towards ribosomal, and it produces the less resistance. And these liposomes basically formulated and coated with polyethylene glycol to avoid immune removal and prolong their stay in the bloodstream. Preparation has four indication, that is doxorubicin liposomal are indicated in four different conditions, that is AIDS related Kaposi sarcoma, metastatic ovarian cancer, metastatic breast cancer, and multiple myeloma. The dose limiting toxicities majorly is bone marrow suppression and heart failure again, that is cardiotoxicity, as well as head and foot syndrome, infusion related symptoms, that is back pain, flushing, and chest tightness, which are observed in 5 to 10% of the patient. As a rule, the infusion symptoms begin with 5 minutes of infusion onset, and when the infusion is interrupted, don't return when the infusion is resumed at a slower rate. So it's all about doxorubicin. Another drug is daunorubicin. Daunorubicin is also available in conventional and liposomal form, but here we have discussed only the daunorubicin generally, generalized way. Like doxorubicin, daunorubicin is again intercalate with DNA and inhibits DNA and RNA synthesis. And the drug is also act during all phases of the cycle, but cytotoxicity is greatest during S phase. So you may call is cell cycle phase non-specific drug. Daunorubicin is available in both forms, as I told you earlier. The conventional formulation is used for induction therapy of leukemia, while the liposomal formulation is used for HIV-associated Kaposi sarcoma. The major dose limiting toxicities again bone marrow suppression and cardiotoxicity, and it may also cause nausea, vomiting, stomatitis, and alopecia. And daunorubicin imparts a harmless red color to urine and tears. Another drug is epirubicin. Epirubicin is same as doxorubicin and indicated as IV adjuvant therapy for breast cancer following surgical removal of the primary tumor in patients who have axillary node involvement. The epirubicin is combined with cyclophosphamide and fluorouracil in combination therapy. Epirubicin is given in repeated 21-day cycle consisting of either 100 milligram per meter square on day 1 only, or second type of regime is 60 milligram per meter square on day 1 and 8. So most of the patients get epirubicin offers no advantages over doxorubicin because the mechanism of action is same, because the toxicity is same. So doxorubicin, just like doxorubicin, epirubicin intercalates DNA, interrupts the DNA and RNA synthesis, causes the DNA strand to break and disrupt the function of topoisomerase 2. Epirubicin is considered as cell cycle phase non-specific. Cytotoxicity is maximum in S and G2 phase. Yes, epirubicin is again available in IV infusion. Hepatic metabolism is occurred by excretion in the bile and urine both. Elimination is slow in patient with liver dysfunction secondary to hepatic metastasis or other causes. Come towards the adversities. The most severe adversity is again bone marrow suppression and cardiotoxicity. And to reduce the risk of severe cardiac damage, the total dose should not exceed 900 milligram per meter square. As if we compare the doxorubicin maximum dose is 550 milligram per meter square, the epirubicin has a maximum range of 900 milligram per meter square. Fortunately, epirubicin is available to use for adjuvant therapy, and the cumulative dose should be well below the safe limit. Extravasation can result in severe local tissue necrosis, and other adversities include alopecia, nausea, vomiting, mucositis, and red discoloration of urine. Next drug is idrabucin. Idrabucin, idrabucin is a structural analog of daunorubicin and doxorubicin. And this drug has only one approved indication, that is the acute myelogenous leukemia in adults, that is AML in adults. Same as other anthracyclines, that is doxor, dono, and epirubicin. Idarubicin again have the same mechanism of action, that is intercalate the DNA to disrupt the synthesis. The causes DNA strand break by disrupting the function of topoisomerase 2. It best works at S and G2 phase and considered as phase non-specific. IV infusion is available. Distribution is rapid, widespread distribution. Elimination is by hepatic and biliary excretion. Principal dose limiting toxicity is again bone marrow suppression. Idrabucin is again cardiotoxic, especially when the cumulative dose exceed 150 milligram per meter square. Other adversities include nausea, vomiting, alopecia stomatitis, and it is a vesicant and can cause severe local injury upon extravasation. Next drug is valrubicin. Valrubicin is indicated for bladder cancer and it is resistant to basil calmite guarine therapy. Goal is to prevent the necessity of cystectomy, that is the surgical removal of the bladder. Valrubicin disrupt action of DNA topoisomerase 2, stop cell growth in the G2 phase. So it is different from other anthracycline and it does not intercalate DNA. The only difference is about regarding the mechanism of action. This drug is intravesical, so administration is directly into the bladder via urinary catheter. It incorporates in a unique diluent castor oil, and because of this, tubing must not contain polyvinyl chloride. Monitoring with cystoscopy or biopsy and by urine cytology should be carried out every 3 months to identify cancer progression or recurrence. The kinetics, the systemic absorption is usually negligible because intravesical administration with limited retention. Bladder wall has erosions or other areas where the lining is not intact. Systemic absorption will probably be increased. Excretion is by urine. Greater than 98% of the drug eliminated intact. That is only 2% is available for the therapeutic activity. Adversities related with valurubicin is 50% of the patient can accept bladder irritation and dysuria with urinary frequency and urgency. 30% will experience hematuria and bladder discomfort, which include bladder spasm. An increase in urinary tract infection and incontinence affects about around 15 to 20% of patients. Another drug is metoxantrone. Metoxantrone is not a true anthracycline, but close relatively structure with these drugs, so it is included in anthracycline. It also has two mechanism of action, that is intercalation of DNA and the inhibition of topoisomerase 2. Cell cycle phase non-specific drug है. Principal application is for prostate cancer and acute non-lymphocytic leukemia. In addition, drug is also used to reduce neurologic disability in people with multiple sclerosis. That is the non-cancer application. Metoxantrone is administered IV. Rapid and widespread distribution occurs. Elimination is slow by hepatic metabolism and biliary excretion. Dose limiting toxicities are bone marrow suppression and again cardiotoxicity. Cumulative dose exceeds when the cumulative dose exceeds 120 milligram per meter square. So the maximum limit is 120 milligram per meter square. Other toxicities include nausea, vomiting, alopecia, and mucositis, and are less severe than with doxorubicin. Some patients develop acute myelogenous leukemia (AML). Metoxantrone imparts a harmless blue-green tint to the urine, skin, and sclera. Patient should be forewarned. Non-anthracyclines. The second group of anti-tumor antibiotics is non-anthracycline, and the drugs available in this group is dactinomycin, bleomycin, and mitomycin. In contrast to anthracycline, non-anthracycline do not injure the heart. So the drugs do have serious toxicities of their own. Dactinomycin is one of the drug, which is also called as actinomycin D. Doxorubicin, like dactinomycin, is a planar molecule that intercalates DNA and distorts DNA structure. As a result, RNA polymerase is unable to use DNA as a template, and hence synthesis of RNA is inhibited. This drug is phase non-specific. The major indications is Wilms tumor and rhabdomyosarcoma. Other indications include choriocarcinoma and Ewing sarcoma, Kaposi sarcoma, and testicular cancer. The pharmacokinetics administration is IV, and because of tissue uptake and binding to DNA, dactinomycin is rapidly clear from the blood. Drug does not cross blood-brain barrier. Elimination is slow and by biliary and renal excretion. Toxicity includes the bone marrow suppression and oral GI mucositis. Nausea and vomiting may be severe. Other toxicities include diarrhea, alopecia, folliculitis, and irradiated areas dermatitis. The actinomycin is a strong vesicant, so extravasation will cause severe local injury. Next drug is bleomycin. Bleomycin is clinically used as a mixture of glycopeptides, and the major components are bleomycin A2 and bleomycin B2. Bleomycin is unusual among the cytotoxic agent, and it can cause very little bone marrow suppression. It can also cause injury to the lungs. Myelosuppression is minimum. Bleomycin could be especially useful in combination chemotherapy, and potential for lung injury often limits its use. Bleomycin binds to DNA, causing chain cessation and fragmentation, and the drug is most effective during G2. Therapeutic uses include testicular carcinoma, lymphoma, and squamous cell carcinomas. The most common uses are testicular cancer and Hodgkin's disease, and it is a most important component of curative regime. Administration is parenteral, that is through IM, IV, subcutaneous, and interpleural. High concentration are achieved in the skin and lungs. Thus, this drug does not enter the CNS, and the tissue contain large amount of bleomycin hydrolase, an enzyme that renders the drug inactive. The major toxicity includes the injury to lungs, and about 10% of the patients. Injury manifests initially as pneumonitis, and 1% of the patient pneumonitis progresses to severe pulmonary fibrosis and death. Pulmonary function should be monitored and bleomycin discontinued at the first sign of adverse changes. Additional toxicities include stomatitis, alopecia, and skin reaction. Hyperpigmentation, hyperkeratosis, pruritus, erythema, ulceration, vesiculation is common in these type of skin reaction. While nausea and vomiting are mild, and other cytotoxic anti-cancer drugs, that is bleomycin, exerts minimal toxicity to bone marrow. So 1% of patients with lymphoma experience a unique hypersensitivity reaction characterized by fever, chill, confusion, hypotension, and wheezing. The last drug which is included in this group or category is mitomycin. And mitomycin is a drug that is converted to active form within cells. Following activation, it functions as a bifunctional or trifunctional alkylating agent, that is cell death caused by cross-linking DNA with resultant blockade of DNA synthesis. Uh, Repeat, the bifunctional and trifunctional activity is that the drug has two or three reactive sites at DNA for alkylation. So, drug is active during all phases of the cell cycle, so it is phase non-specific, and toxicity is greater in G1 and S phase. Mitomycin is used for disseminated adenocarcinoma of the stomach and pancreas. Unlabeled use include carcinoma of the colon, rectum, esophagus, lung, breast, cervix, and bladder. Mitomycin is administered through IV infusion, and distribution is wide but not in the CNS. Drug undergo rapid hepatic conversion to active and inactive metabolites, and metabolites are excreted in the urine. The toxicity is delayed bone marrow suppression for neutropenia and thrombocytopenia, usually occur 4 to 6 weeks after treatment. Mitomycin can also cause hemolytic uremic syndrome, a serious disorder characterized by microangiopathic hemolytic anemia, thrombocytopenia, and irreversible renal failure. Other toxicities include nausea, vomiting, stomatitis, alopecia, and pulmonary toxicity. And again, the mitomycin, like other antibiotic antitumors, is vesicant and cause severe local injury upon extravasation. That's all about the anti-tumor antibiotics, which are grouped into anthracyclines and non-anthracyclines. Hope you understand it well. And if there is any question, ask in comment section or uh, communicate at WhatsApp group. Thank you.